Okay, can I just get people to put their hand up if they've heard of the Churchill Fellowship and they know what it's about? Okay, maybe about half of the people.
We'll go
okay. So the Churchill Fellowship is a memorial trust for Winston Churchill. And so after he died, essentially what he was wanting was a fellowship that was open to a broad range of people and covered a range of topics and interests. And the purpose of the fellowship is really to travel overseas to gain information about whatever your research topic is and bring that back and improve something for the Australian public. And to date, I think it's still the single biggest door knock appeal in Australia's history. So they give out about 100 fellowships per year, and I was really fortunate in 2016 to be awarded a fellowship to look at effective treatment programs for young people with complex needs, so substance use problems and mental health problems. So I guess the background for substance use in adolescents has been covered today, and I really echo the comments of Yufra and Bronwyn and all of the other speakers that are and clinicians working in this space. I guess what I wanted to really focus on is that when there is that regular use together, it really needs a coordinated, specialised, multi-systemic, multidisciplinary approach. And in Australia, that we're very fortunate to have the likes of Bronwyn kind of leading the way in New South Wales, but we really lack that national multidisciplinary leadership and looking at models of care of what works in this group. And essentially that's was the purpose for my travel. So I was away for eight weeks, and I went to a range of different places that were highlighted as centres of excellence. So I, together with Adrian, did a bit of a literature search and looking at the people, key people in the field, and also some centres of excellence. So by all means, this list isn't exhaustive, and there's some fantastic programs happening in other parts of the world, but not everyone's able to host me at a certain kind of point. So this is what the fellowship ended up looking like. So I know that it's probably hard to kind of read all of those and digest all of that information, but essentially the places I went to had something unique about each of them. And what I've tried to do today is have the impossible task of focusing 8 weeks of learning into 15 minutes. And so I will let you know, all the information on these slides comes directly from my report, which I've been told this morning is now published on the Churchill Fellowship website. So if anyone that is looking for the content of this, it's in much more detail. I think the report's about 70 pages, so much more detail than this. So I will just say a little bit about each of the places that I did visit. In Norway, obviously I can't go into too much detail, but I'll tell you about the key factors that kind of stood out to me as being unique or different to our treatment system here in Australia. So Norway, like Scandinavia, is kind of leading the way in a lot of areas. They had a research team that was attached to their clinical teams. So all of the data they collected, they were constantly reviewing and improving their treatment services, which isn't rocket science, but it makes a lot of sense. But I think it was quite unique to all of the places that I went to. And they had on site their inpatient unit, their outpatient unit, the outreach team, the research team, and they also had equine therapists and horses that were used as part of their treatment and have published a lot in that space. Portugal have a very different drug and alcohol system to us, and again, in much more detail in my report around their decriminalisation of substances and how their treatment system responds to that. So I'd recommend having a look at that, because that they've got quite a sophisticated map of how they actually provide treatment services. Toronto went to CAMH, so different to us, they have their addiction and mental health services co-located, and it was probably the best integrated stepped care that I had seen on the trip. They've got a fantastic website, and in their kind of new purpose-built building that's only 5 years old, they're building another one in Vancouver this year. What they had was, your kind of entry level, like this is all for young people, outpatient services, kind of on your lower level floors, and you'd actually, as you'd step up the floors, you'd increase your intensity of service provision. What was really unique about that service is that it was based around dialectical behaviour therapy, and all people working for that service had that training. So in terms of continuity of care from a therapeutic perspective, it wasn't that, if you came to outpatient services here and then you went to an inpatient service over here, you get a completely different model of treatment. You actually got to build your skills and capacity within the young person. So that was really quite a great place, and I got to sit in on some of the groups that they were running there, talking to young people about what worked. So that was really fascinating. And I guess this slide, I was really fortunate that I got to talk with a lot of key kind of international leaders, Yufra being one of those people, but also Sharon Levy in Boston, Kathleen Brady in South Carolina, and Christian Thurston in Colorado. So a lot of research has come out of those centres. Boston had an outpatient-based service, and they were primarily paediatrician-focused and had a really solid kind of developmental approach to their services. South Carolina were doing a significant amount of research and had, I guess, more psychiatrists than I think I could ever imagine working for us in our systems, but they had a contingency we're focusing on contingency management as a way. We know that young people don't necessarily, put their hand up and kind of acknowledge their need for treatment, so they were kind of being quite innovative in the way that they were using the research as a treatment to provide that. So that was really interesting. Colorado was probably my favourite place to visit, just because it was so far outside of the box, and they were being really innovative in the way that they improved access to young people seeking treatment or not seeking treatment, and they actually provided in-reach to schools. And the school that I visited when I was there was more high risk than any of the kind of schools that I can imagine here in New South Wales. They had a very high presence of security guards, kids bringing guns to school, gangs, really, really low socioeconomic area with a lot of parents who were immigrants, so really high rates of trauma in the community. The school was providing food for the kids, so the whole health service basically provided in-reach to this school. And they really clearly divided their treatment. So here we know there's a bit of a divide between mental health and substance use, and particularly when we're talking about for treatment, our CAM services are supposed to be kind of doing mild to moderate substance use work, but we don't know if they're actually always doing that. And the way that they divide it over there is if somebody has a mental health problem but also a substance use problem, they basically go straight to the substance use service, which would really change the whole way that our treatment system works here. But they also had a therapy dog, and they've, I think it's in review now, but are publishing some data on the use of the therapy dog. And similar to equine therapy, I think if I had prescribed that as part of a treatment routine, I'd be deregistered. But over there, I guess what they've shown is that people kind of reach their target much quicker, and people become much more functional in their capacity, and it really helps addressing some of that trauma and helping with engagement. So that was a really interesting place. I talked with you for a lot about the things that he'd talked about today, but I guess New Zealand also is much closer to home, has a more similar treatment model to us, and they've got some fantastic work happening over there and websites, and are more than happy to share and collaborate. So that's an interesting space as well. Okay, I feel like I'm talking really fast because I've got a lot of things to talk about. I've included just one picture in this. I've had a lot of pictures of the places that I went to, but I think this was really important because we're talking about engaging young people. I think the environments in which we see young people is really important. And back in the 1800s, when Oslo Hospital was designed, it kind of looks like a bit of a freaky kind of building, but this was kind of part of a huge hospital, but you didn't feel like that. You kind of felt there, and you felt like you were kind of, surrounded by green and trees, and it's quite a therapeutic space. And I think there's a lot to be done to make our spaces more kind of therapeutic and inviting for young people, and calming as well. So I guess the conclusions of the fellowship was that compared to our overseas countries, we have a bit of a way to go. I think, not surprisingly, those countries that are doing something are better off than us at the moment. I think we have really, in Australia, just really started to acknowledge how big the need is for this space, and it's really starting to gain momentum. Every site I visited talked about increases in referrals over the past 10 years and increase in complexity of presentation. So I think that that's something that we can relate to there. So I guess the main conclusion is there are a whole different range of models of care and a range of different sites that I did visit, but those sites had made a serious commitment to resource and fund these needs for this group. So I guess what was similar, what was different? There was a lot in the places that I visited that were similar. A lot of the services that were provided actually started small and built capacity and were scaled over time. And they had that approach, that kind of staged and stepped approach where you can access treatment at whenever stage you need it, whether that be prevention right through to kind of specialised inpatient care. They were much more well-resourced than we are. But they also had high levels of training. They had multidisciplinary teams. And the goal was always family therapy, regardless of which site I'd visited. The goal was family therapy. And I think that was interesting because everyone had a really completely different model, and the makeups of their teams were all also different. But there was also really well integrated systems. So we know that, I talked about before, about the multidimensional nature and development of addiction. They actually had systems kind of built around that acknowledgement. So there was supports for schools, some of the treatment inpatient units provided credits for school. So it's just some of those things I think that made some of those services quite seamless. I think I've talked about some of that before. Again, I was going to centres of excellence, but the services were really had that embedded culture of clinical research and quality improvement. So there were services that were evolving over time and really quite innovative in the way that they've been doing things, and had that approach of that lean praxis. If it's not working, let's get rid of it and make a commitment to try something new and evaluate that, and a lot of consumer input and input from young people around how things are working. And again, common barriers. We know what our barriers are here in our treatment system, and they're barriers that other countries have faced as well. So what was different? I think I'd kind of touched on those when I gave a bit of a summary of the places that I'd been to. But the models Some people were using outreach, some people were using in-reach. Contingency management was also used. Some people were doing individual groups, some people were individual therapy rather, some people were only running groups. Some places were using an eclectic kind of model where they were providing treatment to young people, and others were using a single-based approach, whether that be DBT, ACT or CBT, were the kind of three main kind of schools, and so the mode of therapy was quite different. Here's just some of the therapies that were being provided across the globe. So I think it shows how complex this space is and how hard everyone's trying to do something. And when you, look at the data, it's not so much, the type of therapy. It's the fact that somebody's doing something and they're actually doing it really well, the way that it was intended to be done. So in terms of recommendations, I don't know how I'm going for time. I won't go through every single, I've got 3 minutes, won't go through everything, but I guess funding and resources we know is really, really important because it's complex work and it's multidisciplinary and it's expensive. But I think there are a range of grants and scholarships and fellowships that we can utilise, and changing the services and the way we respond to this group doesn't necessarily have to attract new money, although that's always helpful. It's about doing things differently. So if you can think about, if there's one thing that you can do differently after all the information that you've got today, what would that be, and how can you make that happen when you go back to your workplaces on Monday? So research, innovation and evaluation, obviously really important as well. I think in Michelle's presentation she touched on new and emerging substances earlier, and we need to make sure we're actually collecting information and data so we're actually responding to that in an evidence-based manner. And collecting outcome data is really important as well. Translational research, I think we know enough about what works in this group, and that became, evident when I was travelling on this trip. If anyone has read the New South Wales Substance Use in Young People framework, there's a lot of great information in there, but we're not always we don't have the models of care to then support that in our daily practice. So we know what's working, but it's not necessarily embedded into our treatment systems yet. Learning from others, I was really surprised how welcoming all of the other services were. There's a lot of information out there and a lot of people willing to share. So if anyone is keen to try, if you do go away and read my report, there are some more information around some of the models in there, and I guess we've got a relationship with those international leaders that are keen to share that. So I think that's really exciting for us here in Australia. Integrated stepped care, we know that comorbidity for mental health is more the rule than the exception, so treatment really should ensure that workers are skilled to be able to manage those kind of presentations. No mean feat, but we need that whole of sector kind of transformational change. We need the partnerships with all of the, government, private and non-government sectors, so we can actually support this group in that kind of stepped care manner. And I think it's hard because we know that young people access support, whether that be mandated or not, through a range of different doors. But so depending on which door they enter, they get a different treatment, and really it should be getting a consistent treatment but with a lead agency. Looking at models of care I think is really important so we can get more consistency and compare, populations, information, treatments, services, so we can actually work out which treatment models work better than others and try and build on that. Again, we need improvements in our workforce and our capacity, and in, using surveys in Portugal, they actually have a treatment demand indicator. So when our kind of surveys go out, so we've got the school-based surveys, they actually match their treatment based on the needs of that survey. And I think we collect the data, but I don't know if that actually reflects our treatment system. Using young people, hearing their voice, having their input across the range of treatments is really important, and for service planning as well. So I guess here's the two recent kind of frameworks that I think is important for us to know about and read to embed in our practice. And some details of the report. If anyone is interested, you can just kind of search the Churchill Fellowship and plug my name into it, and the report will be there. And just some acknowledgements. Adrian encouraged me to apply for the fellowship, and I was very lucky to have got that, and a range of people kind of supported me along the way, so I'm really grateful for that. Thank you.